A very warm welcome to all of you at this webinar on nephropathology of paraproteinaemias. Uh, this webinar was originally uh, presented on 25th of September 2021, and the approximate length of this activity will be about an hour or so. I am Dr. Mohammed Fahim Tungekar. At present, I am a consultant renal histopathologist attached to ExpressMed Laboratories in Bahrain. I am also the director and consultant at Urinologics Limited, based in London. I used to work as a consultant renal histopathologist at Guy's and St. Thomas's Hospital, and I was a honorary clinical senior lecturer at King's College London Medical School, both based in London. Please note that this presentation is copyright and most of the material may be or shall be used in my forthcoming manual of kidney biopsy pathology. Thank you. The story of the paraproteinaemias starts with Dr. Henry Benz-Jones, who was a physician at St. George's Hospital in London in 19th century. He discovered that when urine from a particular patient was heated uh, just above 50 degrees Celsius, a precipitate appeared. And this precipitate dissolved when the sample was heated further. He was not the first one to observe this change, but he was the first one to link it to the patient's disease, which was mollitus osseum, literally meaning softening of bones, and most probably this was a case of multiple myeloma. And then he published his findings in Proceedings of the Royal Society of Medicine in 1847. So this protein was named after him as Benz-Jones protein, and in fact a unit at the St. George's Hospital in London is named after him. Let me summarize for you the topics covered in today's webinar. Before I come to that, there are a few issues about the terminology, because the term paraproteinemia has several synonyms. It may be called monoclonal gammopathy or presence of monoclonal immunoglobulin. This abbreviation MIG will be used throughout the webinar to represent monoclonal immunoglobulin. Another synonym used sometimes is M component, that refers to the presence of a peak in protein electrophoresis samples. The subjects covered in today's webinar are mainly concerned with kidney pathology in MGRS, pathology of kidney in MGRS, or in other words, kidney in monoclonal gammopathy or paraproteinemia. I shall discuss the role of renal biopsy in MGRS diagnosis. I shall illustrate and describe the morphology of renal lesions, and also I shall allude to clinico-pathological correlations and the implications of biopsy findings for management of these cases. Let us recap the structure of the antibody molecule shown here on the left. An antibody molecule is composed of two heavy chains and two light chains. There are these antigen binding sites, two on each molecule, antibody molecule. The segment of the light and heavy chain next to the antigen binding site is composed of variable combination of polypeptides, where the segments away from them are constant. Also notice that there are hidden epitopes. For example, here on the inner side of the light chain, they are hidden because the way the polypeptide chains are folded. However, when the light chains become free, in other words, free light chain, circulate, then these hidden epitopes are exposed, and they are then detected by the antibodies to these epitopes. So therefore, the free light chain assays depend on exposure of these hidden epitopes. Also worth noticing that free kappa light chains circulate as monomers, whereas free lambda light chains circulate as dimers. This has important implications for the way they produce their lesions in the kidney. Now, also worth noticing is that normally a slight excess of free light chain is produced, which is catabolized immediately by proximal tubular epithelial cells, as these FLCs are filtered off in the glomerular filtrate. However, if there is a neoplastic proliferation of plasma cells, there will be an excess of free light chain produced, either kappa or lambda, and then the capacity of the proximal tubular epithelial cells to take them up and catabolize them will be overwhelmed, and then the excess of the free light chain will appear in serum or urine. But on the other hand, even if there is a non-neoplastic proliferation of plasma cells, for example, infections or autoimmune disorders, then again the same situation applies. However, the free light chain, there will be of both types. There will be polyclonal proliferation, so kappa and lambda both will be produced, but they may not be catabolized by proximal tubular epithelial cells because of their sheer concentration, and therefore these may appear in urine and plasma. So the excess levels will be detected in plasma, for example. Um, On the other hand, if the renal function is impaired due to disease, then again the same situation appears, and even normal concentration of free light chain, uh, both kappa and lambda, will not be catabolized by proximal tubular epithelial cells because of disease of the cells themselves, and then the same situation applies, and both the kappa lambda light chain excess will be appearing, will be detected in the serum or urine. Paraproteinemia, or the condition of monoclonal gammopathy, involves secretion of a part of an antibody molecule by a monoclonal proliferation of B lymphocyte lineage. The cells, neoplastic cells producing this abnormal immunoglobulin, may either be plasma cells or lymphoplasmacytoid cells. So the underlying malignancies may be either multiple myeloma or lymphomas or leukemias that are plasmacytoid types. These are the tumors which are likely to produce abnormal antibody molecule. Part of an antibody molecule is produced by these tumors. The light chain within this abnormal immunoglobulin may be either kappa or lambda, but not both. And the heavy chains may be either gamma, which is common, or less commonly alpha or mu, and even rarely delta or epsilon light chains. So there is the possibility of type of paraproteins being present are quite a few. To summarize, therefore, a paraprotein molecule may consist of a free light chain, either kappa or lambda, a free heavy chain, which may be one of the 5 types, or a combination of free heavy and light chain. So all these possibilities exist. Various types of lesions may be produced within the kidney by the abnormal immunoglobulin molecules. It all depends on the way these molecules are processed within the renal parenchyma, and not on the type of tumors that produce them. So the actual processing of the abnormal immunoglobulin within the kidney is responsible for the various types of lesions you see within renal parenchyma. Let's take an example of free light chains, but the same process probably applies to the free heavy chains and free light and heavy chain molecules as well. So let's start with free light chain. If the free light chains are taken up by the mesangial cells, then there are two options. If the abnormal protein is taken up by the lysosome, then due to lysosomal enzymal action, the end product is amylate fibril. On the other hand, if these light chains are taken up by the endosomes, then they end up within an endosome that interacts with the endoplasmic reticulum, and the end product then is a granular deposit, electron-dense deposit, composed of light chains. So already you have two different morphological types produced. The end result either fibrillar or granular. On the other hand, if the free light chain in this example passes through the glomerular filter into the proximal tubule, then again there are two pathways open. As I said earlier, most of the free light chains within the tubular lumina are quickly taken up by the proximal tubular epithelial cells, and an excess of free light chain may end up as crystals within the tubular cytoplasm, or they may end up as punctate deposits within the lysosome, within the cytoplasm of these tubular cells. In both situations, a condition known as proximal tubulopathy is produced, which may result in dysfunction of the epithelial cells. On the other hand, those free light chains that pass through the proximal tubule into the thick ascending limb of loop of Henle, then they encounter there a glycoprotein called uromodulin. They interact with it, and eventually a cast form. And this is the light chain cast formation or myeloma cast formation that takes place here. So, as I said earlier, the way the abnormal immunoglobulin molecule is processed in the kidney decides what form it will take. And this form does not depend on the type of neoplastic proliferation that produced the light chain or abnormal immunoglobulin molecule. Let's briefly look at the test available for monoclonal immunoglobulin or paraproteins. Serum protein electrophoresis is commonly performed. It will pick up levels over 500 milligram per liter. Serum immunofixation is much more sensitive because it picks up levels of over 150 milligram per liter, and it will also inform about the type of the monoclonal immunoglobulin present. Urine protein electrophoresis and immunofixation may pick up levels over 10 milligram per liter, but require a 24-hour urine collection specimen. Talking about the immunohistology, immunofluorescence microscopy, in a case of paraproteinemias, if IgG or less commonly IgA positivity is seen, then you should subtype the IgG type, which is IgG 1 to 4, or less commonly, if IgA is positive, IgA 1 and IgA 2 immunostain should be performed. If kappa or lambda light chain unexpectedly comes negative or is negative, then one should repeat immunofluorescence after protease digestion on wax sections. That increases the yield of positive cases. It was recognized that many of the cases who had abnormal immunoglobulin or had a monoclonal gammopathy, either in their serum and or urine, remained healthy for a long time, completely asymptomatic. Therefore, the significance of this monoclonal gammopathy in these cases was undetermined. So this concept of MGUS or monoclonal gammopathy of undetermined significance was born It was reported first by Kyle R.A. in 1978. The criteria are that the patient has a monoclonal immunoglobulin. There is no evidence of multiple myeloma or a malignant lymphoplasmacytoid neoplasm, either lymphoma or leukemia. There is no evidence of organ involvement by monoclonal immunoglobulin. That means no organ is adversely affected by this abnormal protein, and there's no evidence of malignant plasma cell lymphocytoid lesion involving an organ, right? And generally, these cases remain stable for a long time, and only monitoring is required. And further on, they were divided into MGUS with IgM, MGUS without IgM, meaning other heavy chains being present, and MGUS with free light chains. So this concept of MGUS, or monoclonal gammopathy of undetermined significance, is an important concept because, first of all, the 60% of cases of all monoclonal gammopathies, in fact, have MGUS. The incidence of MGUS is about 3% in individuals over 50 years of age, and it rises to 5% in over 70 years old individuals. So it is not a rare occurrence. And even more importantly, there is an annual conversion rate to malignancy. It's about 1.5%, some series 1%. And also about 23% of cases which are diagnosed as MGUS, in fact, may have renal involvement. So they are no longer MGUS. If they're properly investigated, renal involvement may be discovered. I will not go over these various criteria which hematologists use to define MGUS because today's webinar is mostly about tissue changes. Tissue changes only in renal biopsies. So I shall skip this part. It was also recognized that some cases of MGUS have organ involvement in spite of there being no evidence of a malignant neoplasm being present. Some organs are involved, so they are no longer MGUS. The commonest organ involved is kidney. It's very easily detectable by renal biopsy. And therefore, these cases were called monoclonal gammopathy of renal significance. Kidneys are involved. And this was defined as a state where one or more kidney lesions are present that can be related directly to the abnormal immunoglobulin which is present in the serum or urine or urine. For example, if there's an excess of free kappa light chains, then the pathologist should demonstrate that the renal lesion seen also has kappa light chain restriction shown by the immunofluorescence. Electron microscopy was not required for diagnosis because it is not universally available. There's one exception to this rule, and that is the light chain cast nephropathy. When this is detected, then that is regarded as a marker for a malignant tumor. So when light chain cast nephropathy is identified by the pathologist, then that is considered as indicating as an indication of a malignant tumor being present. So that case then is no longer MGRS. The logical conclusion, therefore, was that the cases of MGRS, the underlying B cell or plasma cell clone, do not require immediate treatment for the malignancy, but they require treatment for the organ itself, organ involvement, organ disease. So no targeted therapy of B cell neoplasm indicated. However, there are some variation in practice, and many hematologists will still treat them, and they have shown that because of the treatment, the organ involvement is also restricted. So there is improvement in the outcome. Also worth remembering is that 35% of cases of MGRS may have cardiac involvement or hepatic involvement that may be more important than renal involvement for the patient's survival. This is the detailed consensus report which was published in 2019. To summarize this again, MGUS is the monoclonal gammopathy of undetermined significance. The monoclonal immunoglobulin is detected in serum and urine. There is no tissue involvement due to this abnormal protein, and action is just monitoring is required for B-cell neoplasm and also to pick up any evidence of organ involvement. MGRS, on the other hand, is a step beyond it, where the monoclonal gammopathy has now caused renal lesions. So MGRS is the presence of renal lesions. Kidneys are affected by the monoclonal immunoglobulin, but there's no evidence of underlying malignancy. The neoplastic process, which has produced this abnormal immunoglobulin, is not malignant, with the exception of light chain cast nephropathy, that is regarded as a marker for myeloma. So it's a myeloma defining event, and therefore those cases are taken out of the MGRS bracket. And 35% of cases of MGRS will have other organ involvement, notably cardiac or hepatic involvement, that may be more significant for the patient's survival. Here the treatment will be for the organ pathology, but there are variations in practice. Some hematologists will treat for malignant tumor as well, as if malignant tumor was present. And then finally, underlying malignant tumor is diagnosed, and then the hematologist will take over. They will treat the malignancy as well as the organ pathology. Let's start looking at some of the renal lesions produced by monoclonal immunoglobulin. The first one to consider is light chain cast nephropathy, also known as myeloma cast nephropathy. Now, to repeat again, this lesion is considered as a myeloma defining feature. So presence of myeloma cast or light chain cast is regarded as evidence that the underlying malignant tumor is present and needs treatment. Now, myeloma cast nephropathy or light chain cast nephropathy, in fact, predicts renal outcomes, which is independent of the hematologic response. So renal survival will be determined by the light chain cast nephropathy. And also in presence of myeloma and biopsy-proven light chain cast nephropathy, the quality of renal response also correlate with overall survival. So it's an important lesion for pathologists to recognize. This cartoon describes the formation of the light chain casts and why do they occur in a particular place, location within the renal tissue. So this is the descending limb of the nephron. Then it goes into the thin limb of the loop of Henle, and that's the ascending thick limb. Now, the flow of the glomerular filtrate is this way. Let's assume free light chains are sort of draining down the loop of Henle. When they reach the thick ascending limb, uh, the cells here produce a protein known as uromodulin. The important function of the protein is to block ascending infection besides other functions. It's a glycoprotein, only glycoprotein produced by the renal system. So that uromodulin itself produces a framework or a nidus which traps the free light chains, and that gives rise to a light chain cast formation. So the light chain casts are almost always seen in this location, sort of thick ascending limb and then distal tubules of the nephron. In a well-established case of light chain cast nephropathy, the diagnosis depends on several criteria. One is that the cast are often angulated, have jagged edges. This is an H&E stain slide, the commonest stain we use in diagnostic practice. The casts are also fractured, divided, and they are invaded by mononuclear cells. Some of them are multinucleate giant cells. The casts are solid, appear to be of solid texture. They damage the tubular epithelium, and that provokes inflammatory reaction around them and also in the interstitium. So very easy to recognize if the casts are many. Therefore, when the casts are many, then it is very easy to pick them up in a simple H&E stain slide. However, when the casts are very few and the pathologist has to screen for them, then it is useful to look at a PS stain, well-done PS stain. Here on the left, you have a case of interstitial nephritis without any monoclonal immunoglobulin being present. And here you see in the PS stain, the uromodulin casts are strongly PS positive. Whereas in a case of light chain cast nephropathy, same stain, PS stain, the casts are rather pale. There will be some PS positivity present, faint PS positivity because of the presence of some uromodulin mixed with the light chain. Because the light chain themselves are pure proteins. They don't have any glycoprotein within them. So they are therefore pale in PS stain. Notice that the casts are fractured, they have jagged outline, and in this one particular tubule has been damaged by the cast, and there is surrounding inflammation as well. So PS stain, well-performed PS stain, is a useful screening slide to go through if the casts are fewer in number. Rarely, the light chain casts may be crystalline in texture. As you see here, the casts are bright red in color, and they have a crystalline structure which are stacked together, causing the interstitial inflammation as well, provoking some inflammatory reaction within the cast as well. But this is a rare occurrence. Immunofluorescence microscopy for the light chains will confirm the diagnosis. Most of the casts are of the kappa light chain type, and here is one showing the typical fractured outline of the cast and strong kappa positivity and negativity for lambda for the same cast. Immunoperoxidase on wax section also will confirm the diagnosis again. Kappa light chain staining showing strong positivity in the cast, whereas the lambda light chain staining is almost negative. Here is another example of immunohistochemistry peroxidase on wax sections performed for light chains. On the kappa stain slide, there is this positive cast, which in the corresponding section stained for lambda light chain is negative. So easy to recognize light chain cast nephropathy, kappa type, usual type, fairly easy case. However, if the casts are too few, then it becomes a tedious exercise for the histopathologist. The reason is that many of the casts which are positive in those cases are positive for kappa will also be positive for lambda. For example, here, the periphery of the cast is positive for kappa, with the same cast, similar casts are also positive in the periphery for lambda. The trick here is to look for and identify a clearly negative cast, say in lambda light stain slide, clearly negative, and then try to find the same cast in the section stained for the other light chain. So negative cast you look for first, try to find the cast, same cast in the kappa stain slide. If it is positive, you are picked up. So this increases the yield of positive cases, and it is also much faster method of picking up the light chain restriction in peroxidase stain slides. Now, this particular slide is very busy, but is absolutely critical because it describes and classifies the whole spectrum of MGRS lesions. Now, this classification is mainly based on the nature of deposits seen on electron microscopic examination. Now, there are three main groups here. The first group is of organized deposits. The second one is of non-organized deposits. The third one is whether there are no deposits seen on electron microscopy. Now, within the organized group, there is a large category of fibrillary deposits, and largest within this group is that of amyloidosis, which is usually congruent positive. Rare one is fibrillary glomerulonephritis, which is usually congruent negative, but recently a series of cases which are congruent positive fibrillary glomerulonephritis has been described. The second group is those with fibrils with a substructure or peculiar arrangement. These comprise of this one very rare condition known as immunotactile glomerulonephritis, where the fibrils have a microtubular structure. Next is cryoglobulinias of type 1 and 2, which may have fibrils, but may also have just osmophilic amorphous electron dense deposit without any fibrillar structure. Similarly, Waldenström macroglobulinemia may show fibrils with peculiar arrangement, but may also show just amorphous electron dense deposit. And finally, within this group of organized deposits are those with crystals or immunoglobulin crystals seen. And here the largest category is that of proximal tubulopathy with cytoplasmic crystals. As the name suggests, the monoclonal immunoglobulin takes the shape of crystals within cytoplasm. Some of these cases may not have crystals, but have lysosomal inclusions that are punctate or aggregated electron dense material. So they are called as proximal tubulopathy of non-crystalline type. Clinically, both types are quite similar. Next, there are two rare entities. One is crystal storing histiocytosis. As the name suggests, shows monoclonal immunoglobulin crystals within the cytoplasm of histiocytes. And the other one, again, rare one, is crystal globulinemia, where crystals of abnormal protein are found within the vascular lumina. So arterial lumina or glomerular capillaries lumina, and they may cause thrombosis. Sometimes they are known as, this condition is known as cryocrystal globulinemia, because sometimes the abnormal protein has physicochemical properties of a cryoglobulin. The next group is that of non-organized deposits. Here the deposits are either powdery or granular amorphous electron dense deposit. The largest category here is that of monoclonal immunoglobulin deposit disease, or MIDD, sometimes also known as Randall type deposits. The next category is a tricky one because it looks like any other proliferative GN, like, for example, like MPGN or diffuse proliferative GN, but the difference is there is demonstrable monoclonal immunoglobulin, usually heavy chain, but sometimes heavy and light chain as well, within these lesions. So that's how they differ from the usual routine MPGN or diffuse proliferative GN. The third category here is that of C3 glomerulopathy. Again, it looks like any other C3 glomerulopathy, including dense deposit disease, but the difference is you can demonstrate monoclonal immunoglobulin within the glomeruli, sometimes tubular lumina in this case. And finally, there is this rare entity of of tubular interstitial nephritis, where there are deposits of monoclonal immunoglobulin within the tubular basement membrane. Lastly, the category where there are no deposits seen. Sometimes this is also known as functional abnormalities or fluid reactions because there are no deposits seen. Within this, there is a group where IF is negative for monoclonal immunoglobulin, but there is positivity, obviously, of the monoclonal immunoglobulin in the serum or urine. Uh, but the lesion themselves do not have any deposits, electron dense deposits, neither do they have IF positivity. So you cannot demonstrate monoclonal immunoglobulin in the lesion. Similarly, this entity where there is thrombotic microangiopathy, there is presence of monoclonal immunoglobulin in the serum and or urine, but not in the renal lesion. But just thrombotic microangiopathy is present. Tricky ones to diagnose these two conditions, but they do exist. And then finally, there is this entity when there are no electron dense deposits, but IF is positive for monoclonal immunoglobulin. Now, this differs from these lesions because here no deposits are seen and there is no lesion, no glomerular lesion, no tubular lesion seen. It's only positive for IF. So sometimes it's known as light chain deposit disease because light chains are commonly found, and IF, that means IF only. So that is the entire spectrum of MGRS lesions you can see in the kidney. Note that I have not included here the light chain cast nephropathy or myeloma cast nephropathy because that is not an MGRS lesion. That is recognized as a marker for malignancy. So that is out of the fold of MGRS. That's why deliberately I have not mentioned it here. Now we are going to see these lesions of MGRS one by one. We start with amyloidosis. This is the largest group of MGRS lesions. Over 40 types of amyloid have been described. We are only concerned in this webinar with monoclonal immunoglobulin-related amyloid. So I'll restrict my description to those only. Clinical diagnosis of early amyloidosis is very difficult because the symptoms are vague and non-specific, and biopsy is often relied upon. Depending on which organ is suspected to be involved, a biopsy will be performed. It may be either a renal biopsy or a rectal biopsy or liver biopsy or even a cardiac biopsy or a nerve biopsy. It's important to detect early amyloid. So therefore, we will deal with some of the techniques that may be used to detect early amyloid. Why is it important to detect early amyloid? Because nowadays there are trials being planned where some drugs, especially monoclonal antibodies, can be used to arrest the development of amyloid. So that if the pathologist picks up very early amyloid in a renal biopsy, then the further development of the amyloid may be arrested and the organ may be saved. So that's the logic behind the detection of early amyloid. Now let us put this amyloid incidence in some perspective. If you take all amyloid, then about 86% of amyloidosis is related to monoclonal immunoglobulins, and about 14% is other type of amyloid like SAA or LEC2 type amyloid. LEC2 type amyloid has an incidence in Hispanic population and in Egyptians. Geographically, there is some variation. For example, in developing countries, SAA amyloid, which is secondary to chronic infections like tuberculosis or osteomyelitis, is more common. But even in those countries, MIG-related amyloid is far too common. Now, let's look further into this portions of MIG-related amyloid, monoclonal immunoglobulin-related amyloid. Within that group, the commonest type is of lambda light chain amyloid, nearly 75%. Less common than that is kappa light chain, and rarely there is light and heavy chain amyloid. So in today's webinar, I shall not be discussing the other types of amyloid at all. We will limit ourselves to monoclonal immunoglobulin-related amyloid only. The distribution of amyloid in a well-established case uh, is sort of universal in kidney. That means it affects glomeruli, it affects vascular uh, blood vessel walls, especially arterial walls, and it also can affect the interstitium and tubular basement membrane. Sometimes it also affects tubular cells themselves, but that is rare. The gold standard for diagnosing amyloid in histology is staining it with Congo red, and when it is polarized, it produces a green birefringence. It's a typical case here. Congo red stain produces this salmon pink or orangish red, pale red, uh, positive mesangial amyloid is seen, as whereas when it's polarized, you get this apple green, often called apple green birefringence in the mesangium and also vascular wall. So that's the gold standard for diagnosing amyloid. In a well-established case, it's easy to do it. Also, it doesn't matter where amyloid is. In this particular case, Congo red stain has positively outlined the tubular basal lamina, and in the polarized under polarized light, polarized microscopy, you are seeing green birefringence. If you rotate the slide a little, the tubular basal lamina, which are showing yellow birefringence, will turn green. So it's worth rotating this stage. So in a well-established case, very easy to pick up and diagnose uh, amyloidosis of kidney. So why does amyloid fibril produces this green birefringence when stained with Congo red and seen under polarized light? The answer lies in the way the amyloid protein is organized into fibrils. Now, a common type of organization of polypeptide molecules in fibril is known as alpha arrangement. It is seen in collagen fibers. The direction of the collagen fiber itself and the direction of the longitudinal collagen polypeptide molecule is the same. They lie parallel to each other. So the fiber and the collagen polypeptide are disposed in the same direction. Now, this does not happen with amyloid. In amyloid, this is so-called beta arrangement takes place, whereas the direction of the uh, amyloid fibril itself is this way, whereas the amyloid peptide, the peptide itself lies at right angles to the fibril. And the peptide also, amyloid peptide also has this zigzag arrangement that gives rise to a pleated arrangement. Therefore, is known as beta pleated sheet arrangement. The only other protein which produces this I know of, is silk. The Congo red molecule is a longitudinal molecule that lies within the grooves of this pleat. And one can imagine that millions of Congo red molecules lying parallel to each other in an organized pattern, they have the physical properties of changing the course of the polarized light, and that's how a green birefringence is seen in the case of amyloid fibrils stained with Congo red. As I said, most of the amyloid is of lambda light chain type, and you can demonstrate it by uh, showing the positivity of light chain restriction by using immunohistochemistry peroxidase. Here you see the strong lambda light chain positivity for mesangial amyloid, whereas negative with the kappa light chain. One can also perform immunofluorescence microscopy for light chain Uh, in this case, the amyloid is stained strongly for lambda light chain as expected, both in the capillary wall uh, as well as in the mesangium, whereas kappa light chain stain on the corresponding glomerulus is negative. Now, in this case, if the results were equivocal or indeterminate, you should do kappa and lambda light chain IF on protease digested wax section, because that will reveal the masked epitopes, and it's more likely to yield a positive result. So it's worth doing this. Sometimes this happens. This particular glomerulus is congruent positive, no doubt about it, yet when examined under polarized light, there is no green birefringence. In fact, there is yellow birefringence, which can be shown by collagen fibers normally. So green birefringence is absent. Even on turning the uh, stage in this case, it was not shown. So this does happen. So are there any backup stains for amyloid? This one stain is in fact congruent itself, seen under fluorescent light. We're using this Texas red filter, and you get this bright brown um, positive stain fluorescence for the amyloid, the same case I showed you earlier, um, and is seen also in the arterial wall. But it's not a specific stain, but it does help in a given clinical context. The other stain that can be used is the thioplamine T stain. Again, the same case, showing strong positivity, sort of bluish birefringence in the glomeruli as well in the arterial wall. Again, it's not a specific stain for amyloid. Can be positive, for example, in dense deposit disease, but it helps in a given clinical context. I mean, there is an MIG present and looks like amyloid, thioplamine T is also positive, then that really helps. This is a case of early amyloid, a well-done Jones stain on a really thin section shows these stacks of spicules, parallel spicules, seen uh, segmentally along the capillary surface. These are not the spikes seen in membranous GN because they're stacked together and they're too long. And in another part of the biopsy, one could see mesangial eosinophilic uh, expansion and also very small areas of congruent positivity. So very early amyloid can be picked up before it is well established in large amounts. Uh, Electron microscopy is quite helpful in picking up early amyloid or in general when there is doubt about amyloid. Uh, the typical amyloid microfibril is about 10 nanometers in diameter. It is a solid fibril, non-branching, and is randomly distributed. So the fibrils you see here are oriented in every which way, and they are cut across as well, which shows a solid core. So it's fairly easy to identify as amyloid, but there are differential diagnoses. One is diabetic microfibrillosis, where the fibrils are very small, they are limited to mesangium, and they are PS positive. The whole area becomes PS positive in light microscopy. And there is this entity of fibrillary GN, where the fibrils are very similar to amyloid, but they are thicker. This entity can cause confusion with amyloid because, as the pathologists know, it's not always easy to determine accurately the diameter of fibril, especially when the difference is of few nanometers, 4 to 5 nanometers or 10 nanometers. Very difficult to be absolutely sure. But luckily, More recently, a specific stain has become available, which is against this heat shock protein DNA J9B, which is positive for fibrillary GN, and also is possibility of doing diagnosis by proteomics, which I shall deal with later on in this webinar. So EM is fairly useful to identify amyloid fibrils. Now, how to improve the detection of amyloid in renal biopsies so that especially the early stage amyloid is identified. One old and well-tried technique is to cut thicker sections at 10 macrometers or more. The other one is to rotate the stage when you are looking at Congo red stain slides under polarized light, and maybe you may sometimes get a bit of green birefringence. You can try other stains such as Congo red with Texas red filter or thioflavin T. These are not specific stains but may help in the clinical context in making a diagnosis of amyloid. Also, electron microscopy can be used, and to determine the light chain restriction, one can use a technique known as immunogold electron microscopy, where different size gold particles are used as an immunostain, and by showing that the amyloid fibrils are adherent to, or the gold particles of a particular size are adherent to amyloid fibrils exclusively, we can then establish the light chain restriction within the amyloid deposition. The other technique is more recently available, but only in few centers, and that is laser capture with mass spectrometry. What is done here is the entire glomerulus is dissected out of the slide using a laser beam, and then it is trypsinized and then subjected to a mass spectrometry process. So very sensitive and very specific technique, and then the spectra are compared with the database of the known proteins to reach a diagnosis. So in other words, it's a proteomics technique. As I said, it's available only in a few centers, but it's only required in about 10% of cases, including rare types of amyloid. The next entity is the fibrillary glomerulonephritis, fairly rare disease. Here, the fibrils seen on electron microscopy are very similar to amyloid, but they are thicker. Most cases are Congo red negative, but more recently, some positive, Congo red positive cases have been described. Light chain restriction is seen in only 20% of cases. And even in those cases, if you use a paraffin immunofluorescence, that means you use pronase digested paraffin wax sections for immunofluorescence, then even in those cases, light chain restriction may not be seen. The specific stain, more or less, being used now is DNA J9B, which is a heat shock protein, which is present positive for glomerular deposits. The laser capture followed by mass spectrometry is useful for definitive diagnosis. Here's an example of fibrillary GN, which in the silver stain section shows clearly split GBM, which is filled by this silver negative material, and also similar material in expanded mesangium. When you use the DNA JV9 immunostain, you see positivity in the areas of silver negative duplicated GBM. So it's a fairly specific diagnosis. It's fairly easy diagnosis to make when you use this immunohistochemistry. But keep in mind that DNA JB9 positivity may be seen in many structures in the kidney, for example, tubules, and to make a diagnosis of fibrillary GN, this positivity must be seen within the GBM and the mesangium. So that's an important caveat to remember. Electron microscopy is important to diagnose this condition. Here on the left, you are seeing expansion of the GBM by this fibrillary material, which in higher magnification shows microfibrils very similar to amyloid, but they are thicker, about 20 nanometers in this case. They are randomly distributed and they are non-branching. Next one is immunotactoid glomerulopathy or ITG. It's a rare condition. Only 0.04% incidence in a recent large multi-center series. So very rare. The characteristic microtubular fibrils are identified, of course, only by electron microscopy. They have about 10 to 50 nanometers external diameter and at least focally arranged in a parallel configuration. Histologically, the pattern is that of endocapillary proliferative, membranoproliferative, or membranous glomerulonephritis. May or may not be associated with crescents. 2/3 of the ITG cases are monoclonal and 1/3 are polyclonal. And of the monoclonal types, they are often associated with low-grade lymphomas like BCLL or B-cell lymphomas or myelomas. In this particular case, the microtubules had an external diameter of about 35 nanometers, and they were situated in the subendothelial space. And the histopathological pattern was this typical lobulated profile of membranoproliferative glomerulonephritis with a small cellular crescent. The formation of the microtubular pattern is not exactly known, but there is a recent report suggesting that similar microtubules were found in the cytoplasm of neoplastic lymphocytes. So there possibly lies a clue about the formation of these microtubules, which are very unusual in appearance. The next in line is the entity of light chain proximal tubulopathy. This condition may occur with or without crystals in the cytoplasm of the tubular cells. Both types have similar clinical significance, and very commonly you see renal functional impairment. There are two types. The tubulopathy may be with crystals, and these cases are usually kappa light chain associated, and those without crystals are maybe kappa or lambda light chain associated. Some of these cases are associated with the tubular dysfunction known as acquired Fanconi syndrome, and there are various types of manifestations. For example, they may have normoglycemic glycosuria, or renal tubular aciduria, or aminoaciduria, metabolic acidosis, and so on. The way to identify this condition at lower magnification is to pick up these massively expanded proximal tubules. The cells are filled with eosinophilic material in this Jones silver stain slide. Distal tubules are not affected. Glomeruli are not affected. In the trichrome stain, this intracytoplasmic material is strongly fuchsinophilic, And this material can also be picked up in the toluidine blue stained resin sections as they are prepared prior to the electron microscopy. And here you see the proximal tubules have this granular material. Some of them can be picked up as crystalline in nature. In routine H&E stain slides at higher magnification, you can just about make out that some of this material is granular, other is has a sort of more straight borders resembling crystals. One can show the light chain restriction by using immunoperoxidase technique for say kappa light chain positivity in the tubular cytoplasm, or in immunofluorescence again kappa light chain positivity in the proximal tubular epithelial cell. I've not shown here the lambda stains for both techniques which were negative. Electron microscopy in the crystalline variant of light chain proximal tubulopathy shows the characteristic crystals within the cytoplasm of the epithelial cells. And in the variant known as light chain proximal tubulopathy without crystals, which can be either kappa or lambda, you find instead of crystals these stacks of lamellated fibrillar tissue material, within the lysosomes, or these punctate inclusions or granular inclusions within the lysosomes. Now we are moving over into examples where there are no fibrils or crystals. Instead, you see a granular powdery deposit representing the abnormal monoclonal immunoglobulin. This group is known as MIDD, which stands for monoclonal immunoglobulin deposit disease, sometimes known as Randall type of deposits. Most of these cases are kappa light chain positive, restricted. The mutations here lie in the variable kappa light region of the kappa light chain framework 4 area, which produces free light chains which are strongly cationic, and they bind to the anionic side on the sites on the endothelium and tubular basement membrane. A third of these cases may have extrarenal deposits in the heart or liver. About 10% of cases have both light and heavy chain deposits. Here's an example of light chain deposit disease. Two glomeruli are shown. They show nodular profiles of the capillary loops, very similar to diabetic nodular glomerulosclerosis, with the difference being that many of these nodules do not have any silver positive deposits, unlike diabetes, because the light chain protein is purely protein. There's no glycoprotein attached to it. So very similar appearance to Chemistyle-Wilson syndrome or diabetic glomerulosclerosis, nodular glomerulosclerosis. Immunofluorescence will clearly show heavy staining of the nodules as well as the basement membrane and sometimes parts of the Bowman's capsule as well for kappa light stain, whereas lambda is almost negative. Electron microscopy is critical for diagnosis. Here you see this powdery granular material coating up the endothelial surface of the capillaries. See, here, 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 almost everywhere, you see the endothelial surface is coated with this powdery dense deposit. The deposit on the right-hand side picture image is less electron dense, but it's also present in the mesangium as well. Similar deposits may be seen sometimes in the tubular basement membrane and also around peritubular capillaries. Some cases have deposits in the Bowman's capsule, as in this one here. Notice again the endothelium coated with similar deposits. Now, this entity of proliferative glomerulonephritis with monoclonal IgG deposit, is an important one, uncommon one, but this is the one where the pathologist has to be very careful, because these cases look like any other diffuse membranoproliferative or mesangial-proliferative GN, but however there are these granular or dense deposits present, and of course there is a monoclonal IgG present in the serum or urine as well. 90% of these cases are in fact monoclonal IgG, of which IgG3 type is the most common one. There never is an IgG4 positivity. The rest of the cases are IgM, IgA, or kappa light chain deposits. C3 is always positive, and only glomerular are positive, not tubular basement membrane, and not the Bowman's capsule. So it's a proliferative glomerulonephritis with this peculiar deposit being present. There's no evidence of cryoglobulinemia, and there's more recent evidence that it has a higher detection rate of malignant clone, so it's almost a marker for malignancy. And it all recurs in allograph, but very few cases have been described. So this is one of the examples of the condition. It looks like any other dense deposit disease, with the replacement of lamina densa by this uniformly electron dense material with abrupt termination. So it looks like any other dense deposit disease. However, this was kappa restricted. Now, deposits will contain, in addition to the abnormal monoclonal immunoglobulin, it will also contain C3 and membrane attack complex, which is C5b to 9. So this is an additional finding in a case of C3 glomerulopathy. Next entity to consider is the cryoglobulinemia of type 1 or 2. This particular case was type 1. Here you see in the silver stain what look like thrombi, but these are pseudothrombi. These are in fact aggregates of IgG and sometimes IgG and kappa light chain monoclonal immunoglobulin. The reaction may be, in addition to the xerothrombi, there may be endocapillary hypercellularity and inflammation. This is an IgG stain, strong IgG positivity for these xerothrombi, and many of the cases, but not all, many of the cases will show this curvilinear deposit, each fibril within this curvilinear deposits is about 30 nanometers in this particular case in diameter. The next example is of Waldenstrom's macroglobulinemia. This had been described long time back in the 1960s. Association is usually with the lymphoplasmacytic lymphoma with IgM paraprotein. The glomerular lesions are due to cryoglobulinemia, which often exists, and it's very similar to that disease entity with xerothrombi, which are IgM positive, however, with light chain restriction. These cases may also show other lesions like amyloid, minimal chain disease, membranous GN, and other lesions of monoclonal immunoglobulin deposits as well. Tissue pathology looks like that. This one here, you see, again, xerothrombi, very similar to cryoglobulinemia, with the exception is that these are thrombi, so-called pseudothrombi, are IgM positive with kappa restriction, and electron microscopy shows similar lesions in some of these pseudothrombi, fibrils with a peculiar annular or curvilinear arrangement, but more often the macrothrombi are just amorphous electron densities. Next is a very uncommon condition which is very similar to an interstitial nephritis. Here you see on the left a typical tubular interstitial nephritis, areas of tubulitis, interstitial inflammation. However, it was showing a kappa light chain restricted TBM positivity along the tubular basement membrane. Next in line is a very rare condition known as crystal storing histiocytosis. Only about 113 cases are described. 80% of these cases are with myeloma or lymphoplasmacytoid leukemia lymphomas with monoclonal gammopathies. However, 20% of cases are with autoimmune disorders, and these are essentially polyclonal gammopathies. The hallmark of this condition is presence of crystalline inclusions in tubules and macrophages. And if kappa variant is seen, then that is more likely associated with Fanconi syndrome. The Lambda variant usually is without Fanconi syndrome. So this is the example of the rare crystal storing histiocytosis. My thanks to Dr. Maria Suarez of Department of Cellular Pathology at Oxford University Hospitals, Oxford, UK, for her kind permission to show me her case. What it shows here is that in the Jones-Silver stain, the glomerular capillaries are stuffed full of these histiocytes with abundant cytoplasm, and the content of the cytoplasm of these histiocytes is kappa light chain positive and is negative for lambda light chain. Now, similar histiocytes may be found in the interstitial tissue of these kidneys. The electron microscopy in these cases shows abundant crystals in the cytoplasm of these histiocytes within the capillary lumina. These crystals are of various shapes and sizes, more seen here. And as the light microscopy shows, they are filling up completely, occupying the capillary lumina of the glomeruli. So again, my thanks to Dr. Suarez. And now we come to this rare entity of crystal globulinemia, sometimes also known as cryocrystal globulinemia, because the abnormal paraprotein here may have cryoglobulin-like physical properties, cause thrombosis as a result of those properties. Now, in these cases, the abnormal protein may be light or light plus heavy chain monoclonal immunoglobulin. You see deposits of crystals, this abnormal protein crystals, within the capillary lumina as well as within the arterial lumina. This may cause thrombosis when cryoglobulins are present or cryoglobulin-like properties are present, or even without them. So in this particular case, you see a clear thrombus found next to the crystals within the arteriole. Now, another important feature to note is this can cause not only renal arteries, lesion in the renal arteries, but also extra-renal arteries. For example, the skin may be involved. And it's also possible to see renal infarction because of the occlusion of some larger caliber arteries. Next, we come to these entities where the patient has monoclonal immunoglobulin in her serum and or urine, but not in the renal tissue. So first entity to consider here is C3 glomerulopathy. Uh, these cases, as I just said, have abnormal monoclonal immunoglobulin in the uh, system, but the renal biopsy shows a simple uh, classic C3 glomerulopathy lesion, either dense deposit disease or other type of C3 glomerulopathy. So you can demonstrate C3 and membrane attack complex in the deposit, but not monoclonal immunoglobulin. So there is no light chain restriction, there is no heavy chain restriction. Now, why does it happen? It's considered that the abnormal immunoglobulin can act as an antibody to complement factor H or to complement factor B. And these both factors are required as a regulator of the complement activation pathway, the alternate pathway. Therefore, there is overactivation of the alternate pathway, resulting in deposits of C3 and membrane attack complex. Um, so that is believed to be the way C3 glomerulopathy is produced in these cases. Um, it is said that the masked monoclonal immunoglobulin can be seen in 15% of C3G cases if you use protease digestion on wax section and then do IF. So those cases will not belong to this entity. And some of these cases have C4D positivity as well. Here's an example of C3 glomerulopathy in which you have this typical dense deposit disease, abrupt termination of this heavy, uh, heavily electron dense deposits within the lamina densa, and immunofluorescence only showed C3 positivity. No immunoglobulins were positive. There was no light chain restriction, no heavy chain restriction. So it was a typical case of C3 glomerulopathy, with the exception that the patient had monoclonal immunoglobulin in the uh, in urine and or serum. The second entity to consider in this type of lesion is that of thrombotic macroangiopathy, where the patient has an MIG present in the serum and or urine, but not in renal tissue. So IF for renal tissue is negative for monoclonal immunoglobulin. So you cannot demonstrate light chain or heavy chain restriction in the tissue, and the patient has a thrombotic macroangiopathy. Effectively, this is a type of atypical HUS. Um, why does it occur? It is considered or believed that the monoclonal immunoglobulins may act as an autoantibody, either to von Willebrand factor or to ADAM TS13 or complement component. So it acts as an anti-factor H antibody. And more recently, a small series has been published where antiphospholipid syndrome was present because of monoclonal antibodies were active against platelet membrane glycoprotein 1b antigen. It is also described in C4 glomerulopathy. Yeah, here is an example of such a case. Uh, Shown here is a trachrome stain that shows arteriolar thrombus as well as glomerular capillary uh, luminal thrombi. In this case, there was no MIG that could be demonstrated in the renal tissue. And finally, this is uh, an uncommon uh, type of lesion where only immunofluorescence is positive in the renal tissue uh, for light chain. So it's sometimes known as light chain deposit disease, only IF positive. So there is actually no deposit by electron microscopy, But as against the previous entities I described just now, there is in fact demonstrable monoclonal immunoglobulin uh, shown in the renal tissue, but there are no renal lesions. Electron microscopy is negative for any deposit. More recently, it has been described that some of these cases may transit to a classical light chain deposit disease, meaning therefore that some of these cases may show later on electron dense deposit on electron microscopy. And here's an example of what these cases may look like. It's a kappa light chain stain which shows positivity of the tubular basement membrane, glomerular capillaries, and mesangium. Lambda is completely negative, and routine microscopy showed no lesions, no renal lesions. So the only abnormality was that the patient had a monoclonal gammopathy in his serum and urine, and the histology showed no lesion except for this light chain restriction. And lastly, I have included this example of invasion of renal biopsy tissue by monoclonal immunoglobulin producing B type chronic lymphocytic leukemia. Here you see the residual glomerulus. Otherwise, the whole renal parenchyma is diffusely infiltrated by this sea of small lymphocytes. This actually was a lymphoplasmacytoid leukemia, and of course is CD20 positive. Now, we did not see any evidence of monoclonal immunoglobulin deposit either by EMR or by immunofluorescence microscopy. That may be because all the architectural landmarks were obliterated by this diffuse infiltration by the leukemia itself. A question is sometimes asked whether renal biopsy is really essential in investigation of monoclonal gammopathies. The answer appears to be yes, because the biopsy of the kidney often reveals unexpected lesions, which may be related or unrelated to the monoclonal gammopathy per se. Also, renal biopsy may be positive for deposition of monoclonal immunoglobulin when serum and our urine levels of paraproteins are low. And just remind ourselves that myeloma cast nephropathy in fact defines or is a marker for a malignant hematologic neoplasm, myeloma, or lymphoplasmacytoid lymphoma, leukemia. So its detection is an important diagnostic feature, and myeloma cast formation itself often predicts the renal outcomes, which is independent of the hematological response, and also the extent of myeloma cast and interstitial fibrosis, tubular atrophy score in renal biopsy will often predict the overall survival of the patient. So definitely useful. Renal biopsy is in general investigation of a case of monoclonal gammopathy. In summary, therefore, in today's webinar, I have tried to show that a wide spectrum of monoclonal immunoglobulins producing B-cell neoplasm are involved. The physicochemical properties of monoclonal immunoglobulin determine types of renal lesions, and the types of renal lesions are not determined by the different types of underlying neoplasm. See, whether it's a plasma cell myeloma or lymphoplasmacytic lymphoma, leukemia, that doesn't determine what type of the renal lesions will be present. So therefore, renal biopsy is an independent investigation, independent of the hematological investigation. Renal lesions caused by direct deposition and less commonly by interaction with alternate complement or coagulation pathways. The biopsy itself identifies types of lesions, how extensive they are. It informs on management, and it also predicts hematological response and survival. And an important point which I have been uh, reminding you of is that for immunofluorescence staining, it is necessary to do subtyping of heavy chains, and for light chains, please try to do uh, repeat light chain stains on pronase digested wax sections if the results on initial immunofluorescence microscopy for light chain staining are equivocal. Thank you very much.